am really honored to be spending the morning with you. I love nothing more than to be with other family medicine providers. We are unlike any other group, so it's a real joy to be with you this morning. I hope that this morning is a chance for us to talk about some things happening that are exciting here in our community, working at that interface between what we do in family medicine and what we do in primary health care, and what is happening at the population level, in large part thanks to our amazing public health colleagues here in the community. So I hope we can spend some time walking through that. I have a little bit of audience participation too, so go ahead and get your cell phones out if you want to text in some things. I definitely want to see what this group is thinking. Isn't that a beautiful picture of our city too? I love Cleveland. I'm a huge Cleveland Browns fan, and someday I believe that I will be able to watch them in the Super Bowl. So now I've lost all credibility with most of this audience, but it's okay. All right, this takes just a second here. Hopefully it'll go. There we go.
Ancient Egyptian warriors traveling for endless days and nights across infinite desert plains, showing signs of endurance and bravery I could only dream of epic. He would tell me that upon their return home, these warriors would be welcomed with a feast worthy of their bravery on the battle. Years later, as a teacher in Greater Washington, D.C., I do now find myself traversing a desert, though it is not the one I envisioned. A food desert. It's categorized as a poor urban area where residents cannot afford or are not given access to healthy foods and grocery stores. Every day at 2:45, I watch my students hop on this leaking submarine of a school bus. Every block brings them deeper into an ocean where the only fish they find are fried, where fruits and vegetables just can't be found because there are no grocery stores here. Just liquor stores and Popeyes, Dunkin' Donuts and 7-Eleven's children born into a neighborhood that feels more pollution than solution. It is then I realize that I am not too far from the desert I once dreamed of. See, whether it's Anacostia or the Sahara, it doesn't make much difference because the Whole Foods, Southeast DC, is no different than the Serengeti to them. Brown-skinned little boys like my students are nothing more than walking cacti, just a piece of scenery this world has taught everyone to stay away from. Rihanna literally has a landfill in her backyard, but she has a hard time convincing herself the world doesn't just think she's trash. Restaurants come and dump the remains of food she'll never be able to afford to eat 3 steps from her back door. Jose, he's back food 5 days a week because his mother works 3 jobs to take care of 6 kids. He only sees her son when she arrives home from work. At the same time he's leaving for school, he has gotten so big that the excess fat buncoming in his skin with added pressure on his joints and knees are literally crumbling under the weight of this world. Olivia watched her father shot 2 feet from her front porch. She wants nothing more than to go outside and play at the park after school, but gun violence has made a merry-go-round feel more like Russian roulette, so she doesn't go outside. Simply eats any processed food from the cabinet that will last long enough to prevent her from leaving the house too often. These are my students, my warriors, fighting a battle against an enemy they cannot clearly see. These kings and queens meant to feast, not to fester, but their zip code has always told them that their life expectancies are 30 years shorter than the county 7 miles away. I can see the pulse of my own ancestry shaking in their eyes. Diabetes and high blood pressure run through the roots of my family tree. Heart disease is as much a part of my history as shackles and segregation. So from my father's kidney transplant to Olivia's asthma, these things are more than mere coincidence. Both grew up in places more accustomed to gunshots and gardens, so tell me place doesn't matter. Like the neighborhoods that are predominantly healthy aren't the same ones that are predominantly wealthy, because when you're not choosing between buying your medicine and your groceries, health doesn't have to be a luxury. Doesn't have to be an abstract concept presented in academic journals and policy briefs. My students overcome more every day than I will in my lifetime. They are the roses that grew from the concrete, the budding oasis in the heart of the desert, and their lives are worth far much more than the things that this world expects.
So that video pretty much transformed a big part of my career a few years ago when I began working with our County Board of Health on thinking about what upstream means. What does it mean to be a family physician in this community, thinking upstream? And when I saw that, excuse me, I knew that Clint was talking about his students, but he was talking about my patients too. And that has become a go-to for me. Whenever I feel like it's too hard, we're getting killed, primary care isn't valued, I go back to that and I think about our patients, we are partners with our patients, and that is what we need to be doing with them. So I hope you find that of value. You can find it on YouTube, and he's an amazing social justice warrior who inspires me every day. So look up some of his other stuff. He says it far better than I ever could. I wasn't sure if I needed disclosures, but anytime I ever talk in front of any group with medical students, I'm told I need a disclosure. So I figured I'd have fun and tell you that I'm a very proud family and public health physician, and that I'm completely sold out for achieving health equity and whatever that means with regard to partnerships and collaboration long term. So I hope you see that through the rest of this talk about what we're doing here in the Cleveland community. All right, so get your cell phones out. These slides just take a moment to pop up. All right, so if you text, and I couldn't get my name off of there, so I'm not being ridiculous having my name in the thing. It's just what it gives you when you sign up for the account. But text Heidi Gullett 063 to 37607, and then put in why family medicine, however you want to interpret that question. So in case it's hard to see, it's my name, HEIDIGULLETT 063, and you have to put in 37607. Give it a minute. And I have a couple of these throughout the talk, so you don't have to do this again. You just put in your answers from this point forward. Social justice. Treat community. Longitudinal relationships. So you can see the word cloud begin to form, and the things that are typed in more become larger and larger. This is why I love FMEC. This is why I love family medicine. Right? So you can see what we're all in this together doing. Right? Why family medicine? Because that's the platform that we have to do all of the things that you've all written here. So why does this matter to me? Well, you heard Chrissy talk about our roots of Youngstown, and so she had to know that I was going to put a picture of Youngstown in here. But really, Youngstown is kind of the reason that I continue to come back to why this matters to me. Why does all of this work about equity and inequities really matter? Well, I grew up in a town that was booming in the time prior to the 70s, and then during the time I was growing up, steel jobs left, things became deserted, and through an interesting twist of fate, I ended up practicing through the National Health Service Corps back in the town where I grew up, just actually about 2 miles from where I was born, in Youngstown. And I became really keenly aware in the first few days I was there that things were much different than what I'd grown up, because I left, I went to college, I went to medical school, I went to residency, and I had served in a community health center in a rural part of East Tennessee. So I had been gone a long time, and I realized that, wow, things are really, really different in Youngstown. But this is the place I grew up, this is where my family lives, and social determinants of health have really changed this community, and the inequities that I was seeing were really profound. And I realized that they were far more than disparities, far more than just the differences in populations based on certain demographics. They were actually inequities, which are avoidable, unfair, and unjust. And there are systems and structures creating those that we can actually tackle. So this is very personal to me, on top of being very professionally important. I also wanted to share a little bit about my background. So as I've gone through my training, I've been out of residency 10 years. I had to do my first board recertification. I get kind of nervous the first time around. You think, did I forget everything I learned in residency? But it's okay, it's fine. If you're practicing, you're good to go. But anyway, so I feel like I've been out a while now. And I realized along the way that things have really transformed for me as far as what I actually think family physicians do. You know, when I first was a medical student, I knew I wanted to be a family physician. And I had some amazing mentors at Wright State University who really helped me see the beauty of full spectrum family medicine, who helped me fall in love with maternity care, which I did for 10 years. And I realized that family medicine was exactly what I wanted to do with my life. But what I didn't realize were all the other things that family medicine allows us to do with populations and with communities. And so through the course of my residency training and my time in the National Health Service Corps, I've realized a lot of different platforms that we can use family medicine for. And that's part of what fed into this topic today around family medicine being a really important voice for health equity. But it wasn't until very recently that I realized the importance of my role as a family physician also being for the people I work with. So I'm going to talk at the very end about a program that we've begun here in town that really looks at also how, as family physicians, we can be partners for the people that are our coworkers. I worked for many, many years alongside people who were living in poverty or at the edge of poverty or struggling with really profound determinants of health themselves, but never realized that that's a place where, as a family physician, I can also impact things. So this journey is not over, and I'm learning a lot, but I wanted to sort of highlight the fact that even as a medical student, or if you've been in practice a long time, you continue to learn how family medicine really unfolds into these other areas where you can impact things. I also wanted to share that I do clinical care at a federally qualified community health center here in town. I've spent most of my career in community health centers, and it's a really unique place to practice, but comes with certain challenges. And so throughout this morning, I'm going to talk a little bit about some of the ways we're trying to address equity through the community health center movement. And also wanted to talk about the fact that our Cuyahoga County Board of Health has been an incredible partner with regard to what we can do around equity. They are really the backbone for this community with regard to building capacity around understanding equity. And I'm going to dive into what that is in just a couple minutes. But it's important context for you to understand that none of this can happen alone, just us as family physicians. We're a really important voice and a really important part. But reaching out across boundaries and realizing that our public health partners and our academic partners and our clinical partners in FQHCs and hospital systems are critically important. And if we come together, we can actually start moving upstream. And that's a really important lesson that sounds like common sense, but is really hard to do in practice. And so a lot of what we're going to talk about today is because of these different organizations really making a concerted effort to do things differently, to do business differently. So I do a lot of teaching at Western Reserve Medical School, and I see some of my amazing students here in the audience. And one of the things I like to say to them is that I view every single one of them as change agents, and I hope that every single one of you also view yourselves that way in family medicine. We are true change agents, and it's not just for that individual encounter, which is incredibly important, but we're so proximally, intimately involved with those social determinants of health and all of those systems and structures that impact our patients every day, that we have a really unique window into seeing what our patients experience and thinking about how systems, structures, and policies can be impacted. So that's my theme for the morning, is especially for the medical students and residents that are here. Please know that we need you, and you are our change agents. We need to be them as well, but we need another generation of folks who believe that they can actually make a difference. And I know some of you in the audience already have. So I've done a lot of thinking about the role of family medicine. So not just family physicians, but our family medicine nurse practitioner and physician assistant colleagues who really believe that family medicine and generalist practice are incredibly important. So I've done a lot of thinking about how do we fit into the picture of equity. And there are times where, and I'll probably allude to this a little bit in the talk, where as a family doc doing primary care in the day-to-day, going through all the challenges we face, sometimes I think, wow, how do I even raise my gaze enough to see that we can actually make a difference, right? We're billing like crazy, we're seeing tons more patients, people are adding more patients to our schedules. We knew you wouldn't mind, we just added 4 more people. That kind of thing, like, right, I just want to get home to pick up my kids on time. So, those things are the real things that I think drive burnout and really drive challenges for us. But what's on the flip side of that? What keeps us going? And so a few of these things I wanted to highlight. The first is relationships. So I saw on that word cloud, longitudinal relationships. Relationships are the crux of what we do in family medicine. And I would hope they're really important in every kind of medicine, but in family medicine, I think that's what really sets us apart. I talked with our incoming medical students last July at their white coat ceremony, and one of the things we talked about was the value of relationship. And they had read a book called Stories from the Shadows. I don't know if any of you have read it, but if you haven't, please do. It's by a physician who runs the Boston Healthcare for the Homeless program, and it's an amazing book talking about his career as a generalist, walking through in partnership with people who are living really challenging lives on the edge of social determinants that are pretty profound. But what he comes away with teaching all of us is that relationships are the art and the fundamental elements of what we do. And I believe in family medicine that's true. They're really the cornerstone of our clinical practice, but I've come to learn that they're also the cornerstone of our community practice. What we do in our community really, really matters. And sometimes that also extends to what we do with our coworkers too. So as we walk through this, I want you to think about these key threads and how they come out in some of the examples that I'm gonna provide. The other thing is that we strive to understand our patients in context. And I know the people who've rotated with me probably get tired of me hearing me say that. But there are so many layers of context. And I think in family medicine, that's what we do really well. We have a hard time separating our patients from the family unit that they're in, from the neighborhood that they're in, from the larger community they identify with. And we shouldn't. That's what's important to them. And in order to build therapeutic alliances that actually mean something and get us to the place where people can reach their full potential, we have to understand them in context. We also are really, really close to those social determinants, those profound structural determinants, which are upstream, which I did not learn in medical school. No one taught me how to treat poverty in medical school. No one taught me how to address structural racism. In fact, I didn't even learn what that was until I was out. So those are the things that I find I see in the exam room every day, the things that I know are the reasons that my patients are dying young, not getting the care that they need, not getting the medicines that they need. But I sometimes feel a little overwhelmed by that prospect. How do I address that in the time I have with this person? So I think we have unique insights as family physicians to partner with folks who can help us get at those systems and structures. We also prioritize all levels of prevention. So one of the things I really love to talk about is primary through quaternary prevention, and I think as family physicians we do all four pretty well. But is the upstream stuff, the primary prevention stuff, I think is a little bit harder sometimes outside of our typical vaccinations and healthy eating talks. But we know what it is, and I think we know how to get people what they need. So we have that perspective, that clinical perspective that focuses on prevention rather than intervention, and that's really important in this equity context. And then we also care for individuals, families, communities, and other populations. So I think that we have that population perspective in addition to the individual perspective. And sometimes that creates tension, and sometimes we're at odds with other folks because that's not their paradigm in medicine. But it is ours, and we've got to hold on to that. And we have to fight for every opportunity to have these things be seen. I tell the medical students, fight for every opportunity to build relationship, because you never know when that's really going to be the difference in someone's life. And it may not be your patient, it might be a community member, it might be a coworker. So we're all very familiar. Everyone at every level of the continuum in here is familiar with the social determinants of health, but I really like the way that Dr. Frieden, the former director of the Centers for Disease Control and Prevention, put this together. So we spend the vast majority of our time at the top of this pyramid. I like to think that we're pretty good at doing counseling and education. We try really hard in family medicine education to get every single graduate to be highly competent with all of our motivational interviewing, solution-focused brief therapy, things like that. But we're also pretty good at clinical interventions. You spend your entire intern year basically in the hospital learning how to do acute interventions, and then you go to ambulatory a little bit more. But we're pretty good at that stuff. We're kind of okay in the middle, long-lasting, protective things. I told you just a minute ago, we're pretty prevention-focused, right? So we do some of that stuff. But the stuff on the bottom of the pyramid that you see has the largest impact are the things that are the hardest to get at. And so if we're inspiring change agents in family medicine and they're focused on equity, we've got to be getting at that upstream stuff, which is this stuff at the bottom of this pyramid. I also like to talk about it in this context. So these are a number of studies that talked about the top causes of death in the US. And those of us in medicine, family medicine or general internal medicine or pediatrics or any really other kind of clinical medicine, you're very familiar with the one that I just showed you, right? Those are the typical causes of death, at least for adults. We've got things that we know how to treat, right? We know how to treat diabetes and hypertension and heart disease and those sorts of things. But those aren't really the causes of death. This other study looked at what are the actual causes of death, and we're moving a little further upstream here. These are the things that traditional public health practice a lot of the 10 essentials of public health, they get at these kind of things, right? The things that are a little bit out of our wheelhouse in the office, but probably still within our scope in family medicine. So tobacco, physical inactivity, poor diet, consumption of drugs and alcohol, infectious agents, motor vehicle accidents, things like that. But the actual causes of death are probably these things. And these are things like individual level poverty, area level poverty, structural racism, the things I told you I didn't learn in med school and residency. This is where our collective focus here in this community is moved. And it's because we know that if we're going to make the biggest impact, we've got to get at these systems and structures that are creating the inequities that we see. So part of this is getting a general definition of population health. And if I asked every single one of you what your definition of population health is, except for the medical students who took my class, who would always give me this definition, right? Everybody else might give me a different definition, right? As family physicians, we probably would be similarly in the ballpark, but we certainly would have some minor nuances and changes. This is a definition that I really like from the Health Policy Institute of Ohio. It's not because they're from Ohio, but I think they do really good work. And they kind of help us bring all of us back to a common definition, which is really important when we start talking about that interface of what we do in individual care and populations. But I actually also like this one. So I have 2 small children, and they are fond of the book of the blind mice touching the elephant at different places and describing the elephant differently. Well, that's what this pictograph is really showing you. So this is a population health elephant, and every stakeholder group is touching the elephant in a different place and describing it a different way. And this really resonated with me because I've had so many different conversations about what is population health, and depending on who I'm talking to or what their paradigm is, they're telling me something. They're either touching the tusk or the tail or the back of the elephant or something else. And so I feel like in primary care, and particularly in family medicine, we see a couple of these different stakeholder groups. We may be part of a couple of them with the different hats we wear, but we still don't have a common definition. So it tells us it's really important to continue to think about building a shared agenda around population health that takes into account this notion of equity. So what is health equity anyway? You've been hearing me talk about it for the last 15 minutes, and many of you are probably pretty familiar with it. But I think it's really important for us to take a couple minutes to actually think about what equity is. And in its simplest form, and the common definition we use in Cuyahoga County and the greater Cleveland area, is that equity is the opportunity for everyone to reach their fullest potential. And when you put health in front of it, it's for everyone to reach their fullest health potential. So ultimately, equity, without even the word health, would be our goal. But we are focused on health in our collaborative here, so we talk about health equity. We want every single person who lives, works, plays, sleeps, eats here, whatever they do here, we want them to reach their full potential, because we are only better if we're all reaching our full potential. So that's how we view equity in this community. It is not the same as equality, and I'm going to show you a little bit in a few minutes what I mean by that. So in order to understand equity in this community, you have to understand the systems and structures that get at that. And I'll be honest, I'm going to be very transparent with you. I didn't get this a few years ago. I had the fortune to be put in a position between the Cuyahoga County Board of Health and the medical school where I began to build partnerships. And it was really a developmental type position. What can we do together to improve the health of our community? Improving community health is a key strategic priority of our medical school, which is actually amazing. You know, most medical schools are focused on, teaching and research, which is really important, and we are too. But we also have a third strategic focus, which is improving the health of this community. And so this role was to begin to also work with others in that space to figure out what we could do together. And what I realized very quickly was that I didn't know very much, and I didn't have a lot of social capital in the community. But I was fortunate enough to be in a place where people were willing to teach me, and we had a really widespread effort to build capacity around understanding equity here. And this began back in 2010, and I joined into the show around 2012 or 2013 and have been learning ever since. One of the real big things we did was partner with some folks out of Ohio State at the Kirwan Institute, who helped us understand the impact of history, the impact of context, and of systems and structures that were in place from the 1930s through the 1970s that impacted not only Cleveland, but over 230 other cities in this country, that really changed the way housing policy impacted people, and therefore has a very unfortunate legacy of creating some of the inequities that we see in health outcomes today. I know that you all know we have a problem with inequities, but I wanted to show you what this looks like in our community so you can think more about the things you need to learn in your own communities to figure out what systems and structures need dismantled and reconfigured to get our patients exactly what they need. So this is a redlining map. Many of you are probably familiar with redlining. You hear the concept. I see people shaking their heads, so they kind of know what this is. This report is publicly available if you're interested to learn about Cuyahoga County and you haven't read it yet. But what I wanted to show you today was that this is not just our community. Youngstown, Mahoning County looks the same. If you look at the health outcomes currently, they look the same as the redlining map. So I wanted you to see this amazing overlap of what we've done with systems and structure around housing policy and what has happened to the people who currently live in the community. So this map shows you what Congress passed with regard to housing policy, where in the red areas you got no subsidy for any sort of federal support to buy a house. In the yellow, you got 15%. So essentially no support. And these decisions were relatively arbitrary. For the interest of time, I took out the specific language, but please feel free to go read it. It's really sobering. And you'll see that these areas were very arbitrarily chosen on the basis of race, ethnicity, social class, or considerations of social class. So remember this map. I'm going to look at it again. That map's from 1940. Up at the top, you see the poverty rate. Now this is a poverty map from a couple years ago. It's not much different currently here in the county. And this is a map of the concentration of African American population in our county. So you can see this history of redlining and what it's done to the concentration of wealth or poverty and what it's done to certain races and ethnicities. There's a similar map for the west side of Cleveland that looks at the Hispanic community. Now if you look at the issues that we've had with high-cost mortgage loans and the issues we've had with the foreclosure crisis here, you see very similar patterns. Now let's look at life expectancy. Pretty similar pattern. And this has been repeated multiple times. This is the second of a third map. The third map's a little harder to see from the back, so I use this one. But you can see that we have stark differences in very short geographical areas in life expectancy, highly concentrated in the urban core, and highly correlated back to the redlining map. These are systems and structures and policies that have created the health outcomes that we currently see. I could put up there incidence and prevalence of late-stage diagnosis for various cancers. I could put up infant mortality, I could put up teen pregnancy, I could put up asthma and lead, I could put up all sorts of outcomes that we see, but you get the idea. So equity is not the same as equality, and I think you're hearing me talk about these systems and structures and how they impact it. You may have seen some version of this picture at some point. There's one with a baseball, there's one with a track. You know, people who are running longer distances, they're not going to all be started at the same line when they're on a track, right? Because they wouldn't be ending at the same place. That wouldn't be fair. So equity is really about getting people what they need, where they need, at the right time that they need it. It's not about giving everyone the same thing. And eventually, the goal would be, we would be able to do equality, right? If we had everybody with an equity focus and we got everyone to reach their fullest potential, in a perfect world, equality would then be, right? But it's not. And it's a big difference. So we as family physicians need to fundamentally understand this so that we can take those things that we do really well that I talked about at the beginning and begin to influence this conversation through an equity lens in our communities. Just sprinkled a few of my favorite quotes throughout. So here in Cuyahoga County, we have the Health Improvement Partnership Cuyahoga. So I'm going to talk about this, and I'm going to talk about one more example that is a complementary to this that we're doing here locally. So the first one is really about building this culture of health through an equity lens here in Cuyahoga County. And we're not specifically excluding our neighboring counties, but we needed to start somewhere, and so we started with the county. So our partnership started back in 2010 with a handful of super committed individuals, all right? 50 people or so were really committed. I was not part of the consortium at that time, but have been really privileged to be a part of it since around 2012. We now have actually, this is even an older slide, we now have actually over 1,000 people in our network and well over 300 organizations that are actively participating. I'm going to talk about exactly what we're doing. So this is kind of a busy slide for this kind of presentation, but I didn't really have a better way to show you what we're doing in one big picture. So our outcomes are achieving equity. That's something we just won't compromise on. Our vision, and this is a marathon, not a sprint. We know that we're not going to do this. These systems and structures didn't create these inequities overnight, so it's going to take us decades to reverse the trend. But we're in it for the long haul, even though this is really hard work, and on some days it seems almost impossible, just like some days in the office seem almost impossible, like 6 o'clock will never come, really? Well, it will, and we will get through it, and we'll be better for it. So our big outcomes are achieving equity, improving well-being, and improving population health. So you can see now why we need common definitions, things we all agree on. And well-being is another one that, in the interest of time, I'm not diving too deep in, but ask anybody around what well-being is, and you get a lot of different answers. So building a culture of health, we're really trying to get a shared agenda around these shared outcomes, and it's equity being at the center of that. We have 4 key approaches. The first one is perspective transformation. What does that mean? Well, it means that we need both individuals and organizations to begin thinking and acting differently. So the reason I put all of those logos of the people I work for up is because sometimes I can feel a little like I'm all over the place. Do I work for CASE, or do I work for Neighborhood Family Practice, or do I work for the Board of Health? And in certain situations, I need to be very careful about the hat that I'm wearing. But this work can't be done unless we cross organizational boundaries and we get the perspectives to transform across the individuals who make up those organizations. So we did not start this with perspective transformation as a key approach. We actually started to have a priority area that was focused around eliminating structural racism. We got about 1.5 years in, and we realized this is so fundamental to the work that we're doing that it has to be our primary key approach. We have to change hearts and minds, and we have to do that with data and with story. And until we do that, we really don't have the stage set for any of the other key approaches. So we've actually been doing this particular part for 3 or 4 years, and we're getting somewhere, but it's slow. It's really slow. The next key approach is collective impact, and I have a couple slides that I'm going to talk about in case you're not familiar with collective impact. Many of you probably are. I did not learn about it even in my public health residency, so I want all of you to at least go away knowing a little bit about collective impact and thinking about where your role might be in your community's collective impact movement. And then community engagement, nothing about me without me, and that is hard. There's often lip service to community engagement. We haven't always done it well here. But what we have done is tried to be very intentional about having community members who represent neighborhoods on the ground doing work in the weeds at the table, telling us where we're going wrong, what we're doing right, what needs to be done differently. And part of that was that we took a survey of 5,500 residents of Cuyahoga County, oversampling in areas of highest need, individual participants, volunteers handing things out in lines throughout the county, and we're poised to do that again in the next 1.5 years. So that's a big part of community engagement. And then health and equity in all policy. And what does that really mean? Well, it sounds nice, right? Of course, we as family medicine physicians would love to have health in all policies. And we'd probably love to have equity. I saw social justice pop up there a lot, so we probably all think social justice or some element of equity is really important. But what does that actually mean? Well, that's a lot harder in practice than it sounds. And so we're trying to really create a policy narrative, a policy agenda, and be intentional about where we can integrate this. And interestingly enough, I was just at the accreditation site visit for the Cuyahoga County Board of Health, and something came up from one of the community members about the County Board of Health team leading a health and equity in all policy initiative at the state of Ohio level, getting legislation in that health and equity in all policy would be a lens through which every single legislative agenda would be filtered. So this is the kind of thing that we're trying to get at. So our entire purpose and being began with this, which is an assessment, and it's kind of a busy slide, but let me just boil it down. So first thing was a health status assessment. You're probably familiar with the fact that many of your hospitals have to do community health needs assessments. You'll probably have heard this come up. But your health departments, at least in the state of Ohio, are required to do community health assessments as well. So this started about that. This started about accreditation, right? We're going to do a health assessment so that we can become accredited, but really we care about knowing what matters for our community, okay? It has become so much more now, and while this is not the focus of my talk, I just have to share that we're finally at the point where our hospitals in this community and our health departments in this community are sitting down together to do a shared assessment. And that's not just because the state governor is telling us we have to do it. It's because that's the right thing to do for our community. It hasn't been hard. We don't have every single person on board yet. But through perspective transformation and a collective impact approach, we're getting there. But this all began with just the health departments coming together and saying, what do we need to do to know what matters for our community? We did a community themes and strengths assessment. That's the survey. So we're looking at vital statistics data. We're looking at publicly available survey data, things like behavioral risk factor surveillance and youth risk behavior survey. But we're also looking at those surveys, those 5,500 I told you about. There was a forces of change assessment, looking at an environmental scan. What's out there, right? Right now for us as family physicians, what are our forces of change? Well, you could come up with a lot of them right now, but uncertainty with the ACA is a big one, right? Our reimbursement is a huge one. So these are the kind of things we looked at. And then the local public health system assessment. So looking at what's our infrastructure for public health and how does that interface with clinical medicine. And then the final piece of this was a youth photo voice project, which was incredibly powerful. And it's probably very hard for you to see this basketball slide, but I had to put this picture up. It says, and these are all teens, it says, where have all the hoops gone? These are very, very powerful. This other one was teens talking about race and the way that they communicate with one another. So we came up with 4 key priority areas through those assessments we talked about. And one of them was eliminating structural racism that I talked to you about. And we turned that into a key approach, as I mentioned. But the other 3 that came up from all of those assessments and a facilitated process of looking at the data these were the other 3 things that our community really cared about. So they cared about this racism issue in our community, and not just about implicit bias and the way we interact with each other in ways that are inappropriate or maybe explicitly showing racism interpersonally, but we care about structural systems issues around racism. That came out loud and clear. But the others were healthy eating, active living, linking clinical and public health, and chronic disease management. And that's specifically been focused on hypertension in the last few years. And healthy eating, active living, and chronic disease management have been working together to put fresh fruits and vegetables in corner stores and subsidize those corner stores so that people in the community health centers in those neighborhoods get produce prescriptions and they learn how to get food that's healthy and food deserts. So it's been a really amazing opportunity through some funding with the CDC to actually operationalize those pieces. And then I mentioned what we were doing with linking clinical and public health with the assessments. So what is collective impact anyway? And by the way, I could talk for days about all this work, so if you have any interest, I'll stick around for a while after, but our website is hipcuyahoga.org, and there's a lot of information there with really specific details about our outcomes and what we're looking at. I wanted to just give you kind of the overview. So what is collective impact? Well, I like this slide. This comes out of the Collective Impact Forum, which is a national group of folks learning how to do this work together. How do we partner together? How do we do business differently? And in medicine, that's hard. We've done business the same way a long time. And so getting us to think differently, we got to get out of medical literature and get into social science stuff like the Collective Impact Forum. So they show us we do a lot of individual impact. And this is not just our sector in medicine. This is everyone, right? We all do really good stuff on short-term grant cycles, and we provide our short-term outcomes, and we're pretty happy with what we've done. But we know it's not enough to get at those upstream determinants of health. So coordinated impact, we kind of do that too. In this community, we do some coordinated impact in pockets. Right? But we're all about collective impact, and that's a really intentional way to get at systems and structures, social change in a way that leads to rigorous data analysis and big picture outcomes, big changes for the people in our community so that they can each reach their full potential, everyone. And that's a tall order and seems maybe a little idealistic, but actually think there are a number of places where this is working well, and we have begun to try to operationalize this here locally. So what is in the heart of collective impact? It's equity. And if you don't have that shared agenda around equity, it makes it very hard to have this move beyond a coordinated approach and moving into a collective approach. So equity is really the heart of it. Community engagement is as well, and then cross-sector partnerships. So the one thing I've learned through all of this is that we in medicine cannot do this alone. And I think when we go through our training, we get pretty good at thinking that we need to be pretty self-sufficient, right? Like we kind of give you, especially in family medicine, we're like, we really support you in the nest at the beginning, right? But eventually we kick you out and hope you fly, right? And you need to be pretty self-sufficient. But this kind of work, tackling poverty and tackling structural racism, doesn't work alone. We can't do it alone. We will be burned out and not survive. So it needs cross-sector partnerships. Continuous improvement. Data is a huge part of this, but it's not always quantitative data. We use a lot of that, but there's also a lot of qualitative data. How are people doing? How are they feeling about it? Do they feel that they're valued in their community? Those are really important elements. And then on the other side, you'll see things like relationships, long-term relationships on trust and mutual respect. That also sounds pretty intuitive and easy. It's not. So we learn when you're with people for a long period of time, you have competing agendas and you have kind of a shared agenda, you begin to realize that doing business differently means walking away a little bit from that individual organizational agenda and figuring out what that means when you move over here and you have a collective agenda. That's a big deal, and that can only happen when you have relationships of trust and mutual respect. Local context really matters, and then system stuff matters. So when I say I believe that our medical students and residents and those of us in family medicine are change agents, I mean it. And part of why I mean that is that we have this generation of students, at least the ones that I've been working with in the last few years, that are really great systems thinkers. And we need to cultivate that, because this kind of work can't happen without thinking in systems. And that's really fundamental. And I'm going to talk now about the fact that one of the criticisms we sometimes get, and maybe rightfully so, is that, well, you have a strategic plan and you have an agenda and you're going a certain way, but then all of a sudden you get excited and do something over here. Well, exactly. Right? This is a systems approach. We can't map it all out. Modeling is great, and we can use that for some things, but this kind of work, dealing with poverty and structural racism and other upstream determinants of health, requires a combined intentionality and an ability and resilience to go with emergent opportunities. Things pop up, and you need to use those when they do. And so that's a challenge that we face. It's a constant tension, and I think we face it in family medicine at the microsystem level too. But it's something I wanted to highlight because it's been an area where I think we need to call out more the fact that we can work together differently, and that might just pop up, and we need to just run with it and do it. So there are a couple other clinical forces that I wanted to talk about that are really important for us in family medicine. So one of them is that there's a new clinical focus on population health. In family medicine, I kind of feel like we've been doing that a while, but our hospital systems finally caught up, in large part secondary to the ACA, and they're really focused on population health. Well, it's partially driven by value-based reimbursement changes, alternative payment models coming, right? But whatever the reason, we need to take control of that. We as family docs understand population health, and so that's really important, and population health is going to be done some way. So I feel like we really want to influence that conversation in this community to have equity at the center of all of those population health discussions. If our hospitals are talking about doing population health, equity needs to be at the center, because you can't improve population health unless you think about all the different populations that encompass your market share or the groups you serve. And that's a really important conversation, and not one that's always had at the highest levels of administration. So we as family docs, by understanding that, can impact that. Healthcare reform, value-based reimbursement I talked about. And then there's also this interesting, over the last few years, I've been in various meetings where, I've always thought social determinants of health were important. Like, that's why I'm a family doc, right? Like, I didn't want to go into a field that I couldn't actually think about getting my, partnering with my patients to find the best housing or food or all those things. But in medicine, that hasn't always been the way it is. And so there's this interesting conversation about, well, how responsible should we be in medicine for social determinants of health, right? Should we really be responsible? Is that really in our wheelhouse? And I would argue it is. But again, coming from a family medicine perspective, that's not always the way it's felt about in other medical settings. So I think it's important for us to influence that conversation, and perhaps it's a way that we partner outside of our four walls, whether it's our ambulatory or inpatient facilities, to think about what that means. Is it partnering with our community agencies or with our health departments? And then my particular interest is impacting this kind of paradigm shift in medical education. So I teach a course at CASE that all the medical students go through in the July and August of their first year. And sometimes I get people who love it, and sometimes I get people who hate it. But we talk about population health and determinants of health and health systems and patient-centered care. And I say, I don't care what you choose. I do care what you choose. Like, at least someone, please go into family medicine. But, so I do care what you choose. But even if you choose to do something that's far different than family medicine in medicine, please understand these concepts. They're really important for the person in front of you. So I think it's really important that we begin to continue to push the envelope on an understanding of equity in undergraduate and graduate medical education. And then there are lots of innovative patient-centered care models, but they don't always include equity. And so I think we also have an opportunity there, and with a real change in the way reimbursement is going, perhaps we have an opportunity for some resources that would help us embed equity at the center of what we're doing in our microsystems in the office. So the very last thing I wanted to talk about is another complementary sort of pilot work that we're doing here in the community, and this is called Bridges Out of Poverty. Many of you have heard me talk about it before. I came across this as a resident. So I did my residency, as Chrissy mentioned, in Oregon, and my 4th year, because I did a combined residency, my 4th year I was put in a Medicaid managed care company as one of the assistant medical directors, and I didn't really know what that meant. But I realized quickly it did mean things like reviewing prior authorizations and talking to angry doctors on the other end when things were denied, right, like a CT or something. But I also realized that it meant I needed to think differently about how to provide for a population with finite resources. So we had about 100,000 members who were all on Medicaid, with just a handful of dual eligible folks on Medicaid and Medicare. The vast majority of us, of our members, were on Medicaid. And so I began to think about population level approaches to this. And so the Bridges Out of Poverty work helped me find that framework to really understand how I could impact these populations differently. So I ordered the books, read the first one, then ordered like every other book they had. And the rest is history. So what is poverty? Well, in this context, it's the extent to which an individual does without resources. And we typically think of poverty by financial means, so we think of the federal poverty guidelines. Many of our practices will see people on a sliding scale based on that or what percent they are. But it's far more than that. And so what Bridges does is begin to teach about 11 resource areas, and I'll walk you through a few of the programs we're doing here in town to see how this impacts our patients and our employees. So the more we understand how class affects us and are open to hear how it affects others, the more effective we can be. I know this sounds simple, but it's another one I keep coming back to because I operate by the middle class way of doing business, the middle class hidden rules. That's what I know, that's how I was raised. So that impacts every interaction I have with patients, with coworkers, with administrators, whatever. So learning about how people in wealth and how people in generational and situational poverty see their world has been really transformational for me. So this is the big picture model of Bridges. The big thing I wanted to show you on this is that it's cross-sector again, right? So you're seeing these themes: relationship, partnerships across sectors. So this actually has become an interesting partnership for me with workforce professionals here in the community. I never thought I would be working side by side with human resources professionals, but I have learned an awful lot about workforce, and I've also learned an awful lot about education. So I'm working also with some teachers who were all doing this work and trying to create a system that allows for our graduates of these programs, these Bridges programs, to really begin to have a helpful future story. So part of it is that we provide trainings for people like you guys. So people who are professionals working with people living in poverty, trying to get at how do we address poverty in the context of our work. I have to be honest, I got a little burned out and frustrated as a family doc because I couldn't get at the things that were making my people sick. Right? So that's how I got to this stuff. I was trying to figure out how to do better. But what I've realized is actually that I've learned so much from the people in these programs and the people living in poverty about how to think differently. So we do programs, either Bridges Out of Poverty or Workplace Stability, which I'll talk about in just a second, for people like you guys to help you think about how economic class impacts your thinking. How can you think differently? How can you learn about things differently so that you can better meet your patients where they're at? And then there are programs for people living in poverty that are built on this framework. So the idea is that professionals have the language that's the same language as those living in poverty, begin to develop a hopeful future story, and move out of poverty. That's the whole idea. Equity. Everyone reaches their full potential. So getting ahead in the bottom corner is what we've begun doing with patients here. It's very early, we're just starting, but we are working among community health centers here in town and looking at outcomes, particularly around prevention. I don't know if you've had the experience, but over my career the experience has been it's been very hard to get people to do prevention when they're focused on the tyranny of the moment, the here, the now, focused on housing and food and things like that. It's very hard to think about a colonoscopy that might save myself in 10 years. So we're looking at outcomes like that, but hopefully another time I can come back to this type of venue and talk about what we found and whether it's valuable for patients. And then the others are getting ahead while getting out for returning citizens following incarceration, and then also getting ahead in the workplace. And we're doing this with healthcare employees here in town, helping them develop a hopeful future story and develop more effective ways of working at work. How do you function and work in the middle class way of doing things when all you know is the way you've grown up in the hidden roles of poverty? How do we bridge that gap? And this program is one way to do that. And then we have a program for high school students. We're in about four high schools here in town right now where high school kids are doing a version of this. And we just had the most amazing opportunity to take 2 high school students from this area to St. Louis, and they presented to a ballroom like this of a bunch of people who did not look like them to talk about how their lives have been transformed by developing a hopeful future story and learning about how poverty doesn't have to be their future. So those are the kind of transformational things that I really find this program has given us the opportunity to do. And then I mentioned workplace stability. We've trained close to 55 administrators, senior leadership, and healthcare organizations here in town on workplace stability and help them think differently about how to stabilize their entry-level, lower-wage employees, medical assistants, nursing assistants, food service folks, environmental services. How do we keep those folks stabilized in their positions so they have mobility within the organization, and then they have the opportunity to develop a hopeful future story through programs like Getting Ahead. And I just threw this in here because I wanted, this may sound a little like pie in the sky to you, so I wanted to give you just one concrete example. This is one of the things we do in the Bridges in the Workplace Stability training, is we do a whole module around relationships. And I felt like this was the one that was the most applicable to this group because we do things all the time, and I'm guilty myself in the office of doing things that break relationship. And yet relationship is the paramount, most fundamental thing we do as family physicians. Sometimes that's the only therapeutic intervention we provide, is that relationship. And so this is an opportunity to think very deeply, and we do this over about 2 hours, about how you impact your relationships by the way that class impacts your thinking. So it's just one concrete example of the kind of things we explore. And then we've been doing poverty simulations across town for various groups. I'm doing one for the entire talent acquisition team at one of our major hospitals pretty soon. We've done them for our medical students. We're doing them interprofessional across multiple health professions. So these are opportunities to sensitize people to the experience of poverty by no way approximates it, but begins to help people develop aha moments where they can think about the way that they interact with their patients differently. So finally, I thought that this would be helpful in leaving you with some inspiration in a change agency context. So there is no such thing as a neutral educational process. Education either functions as an instrument that is used to facilitate the integrations of the younger generation into the logic of the present system and bring about conformity to it, or it becomes a practice of freedom, the means by which men and women deal critically and creatively with reality and discover how to participate in the transformation of their world. So I'll jump over that in the interest of time, but I just want to thank Christy and Larry and Kurt and all who gave me this opportunity. I really didn't, I thought, you want me to talk here? But I really appreciate the opportunity, and I appreciate the opportunity to spend the morning with all of you and look forward to learning about you learning from you in the coming hours. So thank you for the opportunity.